While we're getting all those great results from the checkpoint inhibitors, as we just discussed, you have already on board the nivolumab, you have on board the pembrolizumab, you have on board the durvalumab and tremelimumab in combination especially. This is all great news. And in addition to that, looking beyond the systemic disease and looking into combination for local therapy with any of those checkpoint inhibitors plus the actual local therapy, like for example in embolization, by all means is also looking forward. However, a very important question is we need to dissect further who's who in that whole story. While we said that any patient technically is eligible short of certain limitation in regard to checkpoint inhibitors, we have to remember that we don't know yet, and we don't have that sense about who really will respond best. Is it patients based on gender? Is it based on ethnicity? Is it based on the etiology? And especially here, I talk about hepatitis B versus hepatitis C. We all don't have that data yet. The nice thing is we are currently undergoing a major effort worldwide that's collecting tissue from different cohorts of patients with liver cancer all over the world. And we're trying to further dissect what does it mean to be a patient from that specific cohort versus the other in regard to the potential outcome from the use of checkpoint inhibitors. A question that I'm asked all the time is like, how would we know a patient might respond, or how would we know they responded to checkpoint inhibitors or to immunotherapy? By all means, it will be rather difficult to expect who will respond because we don't have yet that sense about certain markers in regard to who might be more potentially able to respond. But on the other hand, how to assess the response? The best is no question is to look at the imaging and look for the response as we all know it. There are certain variants to that, including the iRECIST, which is a form of RECIST for immunotherapy treatment. But more important is to remember something about the potential for a pseudoprogression, where in other words, patients might see further growth in the tumor while they're doing clinically great. And as such, we have already been taught that patients of that nature should continue on the therapy at least for another CAT scan and see if they responded or not. So I would say an assessment for patients with checkpoint inhibitor with HCC is multifactorial, and it's a good idea to open the discussion back and forth with the different players in the game, part of a multidisciplinary team, because the decision making should not be as easy as it's bigger, that means it's not working, or smaller, it means working. There are certain variants one way or the other. This year, 2018, is really nothing more than a great continuation for the excellent story that we have listened to in 2017 as far as treatment for HCC. And if anything, short of the long story of the TKIs that started with regorafenib in 2017, followed by lenvatinib in 2017, and if anything now in 2018, we're going to talk at this meeting about cabozantinib, but also there's a continued story for checkpoint inhibitors. The story started in 2017 with the approval of nivolumab, but at the moment I think probably the biggest two stories is one which is already wrapping up to its final stage, which is nivolumab versus sorafenib, but a very important study is the Himalaya study, which is looking at the combination of the durvalumab plus tremelimumab versus durvalumab versus tremelimumab versus sorafenib. So there's quite a bit going on, and we look very much forward to see how this trial will end up.